Hello, my name is Dr. Eva Altobelli, and I'm a psychiatrist specializing in addiction. Today, let's discuss a few things. The first contact we have with clients, the stages of change, what may affect a client's ability to change, interventions. I'll start with the initial consultation. This is the first time we meet with clients, so we're setting the stage for our ongoing relationship. I believe the motivational interviewing style with a great deal of compassion works best. Motivational interviewing creates a non-pushy, meet the client where they're at type of atmosphere. And it's very important to approach the first conversation with a new client with both an open mind and an open heart. There's already so much shame, guilt, and judgment associated with substance abuse that it's important to create a safe space for someone just to be and to feel comfortable enough to discuss their pain and what drove them to try and numb it. Our initial job is really just to connect, to listen, and to try to gain an understanding of what prompts the individual to use drugs or alcohol and where they currently are in their readiness to change. Let's break down the stages of change, starting with pre-contemplation. These clients are not ready. They only present to you because, for instance, they have received a DWI, and if they want their license back, they're obligated to seek treatment. The next stage of change is contemplation. These clients are getting ready. They are open to discussing the possibility of a problem. The next stage is preparation. These clients are ready to make a plan. The next stage is action. Now, this can take many forms, from rehab to detox, AA, NA, spiritual counseling, family and individual therapy, group therapy, engaging in a supportive network, abstaining from drugs and alcohol, deleting the phone number from your dealer, from your cell phone, telling all your drinking buddies what you're doing so they don't call you and invite you out anymore, and giving yourself the time and space you need to find out what recovery works for you. The next stage is maintenance, which is where you continue what worked for you. I also include relapse, as I see this as an accepted part of the recovery process. In our first meeting, it's helpful to learn where the client is on the continuum. For example, with a client in the pre-contemplative stage, who's really only presenting due to legal issues or an ultimatum by family members, that really offers us very little to work with. There's not much we can do if the client is not truly motivated. And I don't mean motivated for complete abstinence, because the road to recovery has potholes of blame, shame, resentment, and relapse as part of it. But to allow someone to have all of these issues, and as a therapist, be a non-judgmental, supportive presence in their lives is incredibly helpful. Recovery looks different for everybody. What works for one client may actually make another client want to use more drugs. For example, AA is a wonderful, helpful organization for a lot of people. There are some people, however, who have shared with me that it just makes them angry and it makes them want to drink more. Now, sometimes this is real, sometimes it's a defense or an excuse, but we cannot push any particular modality of recovery. Just be present and discuss alternatives. Perhaps yoga and meditation are a better recovery track for some people than AA. For some clients, forgiveness is the hardest part. I find myself saying to clients, I forgive you. And that is at times an incredibly powerful thing for them to hear, because it's so very difficult for them to do that for themselves. Once you've developed an opening into the relationship, you can then try to delve into what causes them to use drugs. Some people simply enjoy the high, and for that population, it's very difficult to get them to stop using until the negative consequences are more powerful than the high. Oftentimes, I'm surprised at how clients minimize their trauma, assuming it's only trauma if it's overt and in your face. In my practice, I've learned the more subtle, covert trauma is as damaging. An example of covert trauma is the almost passive but chronic negative messages one can receive. For example, children who were raised in hypercritical households who always heard they're not good enough tend to develop a tape in their heads, and it's very difficult to unlearn. This leads to how you might think about yourself, insecurities, and will affect the choices you make. Another example is clients raised where there's a great deal of neglect. This can lead to poor self-esteem, attachment issues, and this too can affect the choices you make in your future. For the most part, I find substance abuse to be a result of self-medicating for pain. And again, it's a result of painful emotional experiences stemming from childhood. In opening the door to a client's trauma, be careful not to go too deep. Just identify and empathize. We don't want to pull off a scab and not be there to address a bleeding wound. Let the deeper discussion happen in future weeks with a primary therapist who can be present to deal with the fallout. We're not often taught how to tolerate discomfort. And once we start on the path of self-medicating, it becomes difficult to see another option, particularly because not using drugs is difficult, uncomfortable, and exposes a lot of raw emotions that we then have to deal with. And the longer an addict used drugs or alcohol, the more damage they probably did to their relationships, so the harder it is to come clean. I've seen that some clients hesitate to start the conversation about addiction because they don't want to carry a label, addict, and then they don't want to go further in the conversation and develop more labels, depressed, bipolar. In my practice, I feel offering someone a specific diagnosis, while sometimes helpful, largely can be hurtful as well as unnecessary. It's just a label. It's more important to identify the symptoms and obstacles to sobriety and address them. Insomnia, anxiety, depression, that we can address, oftentimes with psychopharmacology, fancy word for medication management, and a wide variety of therapeutic modalities. Interestingly enough, clients are more willing to take drugs of abuse than prescribed medications. So when I introduce the topic of medications, I go slowly and try to offer as much education as possible. Medications are not something that a client will necessarily need to take forever, just while they're experiencing the symptoms that are getting in the way of recovery. For example, it's hard to engage in your recovery if you just can't sleep at night. I don't think that we should use medications to numb or eliminate feelings, but to make it easier to deal with them, to access them, and to process them. So it's really about education and having a conversation with clients and listening to their concerns. Fears of weight gain, libido change, sedation, developing a new dependence, all of these are common reasons why people don't want to try a medication. However, once a client feels heard and then can be treated like a partner in their recovery, we tend to have a better response. What I'd like to leave you with is that offering a non-judgmental, supportive approach is the best way to encourage your clients to engage in their recovery. Being open to understanding what drives their use, whether it's self-medicating, habit, dependence, escape, working with clients and allowing them to come to readiness in their own time and develop an individualized recovery strategy has the longest rates of success. Thank you for your time.